Let's talk about chronic hypertension in pregnancy. 1.5% of pregnancy patients have chronic hypertension. Diagnosis is defined as onset of hypertension less than 20 weeks with a blood pressure of 140 over 90, 4 hours apart. Severe range is 160 over 110. If they don't go away after 12 weeks, they're also likely to have chronic hypertension, not gestational. Recent changes based on American Heart Association. Stage 1 hypertension is 130 over 80, and stage 2 is 140 over 90. Normal physiologic decrease in systemic vascular resistance can decrease the blood pressure with nadir around 16 weeks, followed by return to pre-pregnancy levels by third trimester. There is a normal decrease in blood pressure about 10% by 7 weeks. Diastolic decrease is more marked than systolic, as much as 20 millimeter of mercury. Types of chronic hypertension, I think it's more like 90% is unknown cause, which is primary hypertension, and 10% is secondary. That's why we should check CMP to check for I think I'll talk about these other secondary causes later. Measurements of blood pressure. So patients should be seated with legs uncrossed and back supported. No caffeine or tobacco for 30 minutes. Cuff should be 1.5 times the upper arm circumference. Position at the level of the heart. Chronic hypertension with superimposed preeclampsia. So chronic hypertension with superimposed preeclampsia, 50% of the women with chronic hypertension can develop superimposed preeclampsia. Women with an organ disease or secondary hypertension have a 75% chance of developing preeclampsia. Other high risks include African American, obese, smoking, had hypertension for 4 years plus, diastolic of 100 millimeter mercury, a history of preeclampsia. New onset thrombocytopenia may be a sign of superimposed preeclampsia developing. We can also see elevated liver enzyme, elevated uric acid, and symptoms of preeclampsia. White coat hypertension. 50% of individuals can have this disease. However, up to 40% of patients with white coat hypertension can eventually develop gestational hypertension or preeclampsia. Effects of chronic hypertension on pregnancy. So maternal, there's a 5% higher risk of stroke, pulmonary edema, or renal failure. Increased risk for GDM, increased risk for C-section and postpartum hemorrhage. For GDM, the risk is 8%. Let's just say 10%. 10% for chronic hypertension versus 2% without chronic hypertension. C-section risk rate is 1.8 times and postpartum hemorrhage rate is 2 times. So, other maternal risks. Where is it? So death, stroke, pulmonary edema, renal insufficiency or failure, MI, preeclampsia, placental abruption, C-section, postpartum hemorrhage, and gestational diabetes. Fetal risks, congenital anomalies, especially heart defects, hypospadias, and esophageal atresia. You can have preterm birth, growth restriction, or death. So fetal growth restriction is 2 times, fetal death is 3 times. Pre-pregnancy counseling. These patients should be avoiding ACE inhibitors and ARBs due to risk for fetal renal dysgenesis and calvarial hypoplasia. They can also cause FGR. We should get baseline tests such as LFT, creatinine, CMP, BUN, CBC, urine protein creatinine ratio. If the ratio is less than 0.15, that usually means the 24-hour is less than 300. Also, we should get an EKG. Secondary hypertension evaluation. If the hypertension is resistant to treatment or diagnosis is less than 30 years, then there should be further workup for possible secondary causes. Box 3, let's see. Okay, box 3 has the risks of, not risks, the possible secondary causes. So if you have blood pressure lability, episodic pallor, and dizziness, you could have pheochromocytoma, snoring or hypersomnolence. You could have obstructive sleep apnea, muscle cramps or weakness. You could have hypokalemia from primary aldosteronism or secondary aldosteronism due to renal vascular disease. If you have weight loss, palpitations, heat intolerance, that could be hyperthyroidism. Edema, fatigue, frequent urination. You could have kidney disease, history of coarctation repair, residual hypertension associated with coarctation, central obesity, face rounding, easy bruisability. You could have Cushing syndrome, medication or substance use such as alcohol, NSAIDs, cocaine, amphetamine. Absence of family history of hypertension. So treatment. ACOG now recommend starting treatment if the blood pressure is 140/90. There's decreased risk for preeclampsia with severe features, medically indicated preterm birth less than 35 weeks, placental abruption, and fetal death. So table 2 has all the blood pressure medications. So labetalol, oral labetalol should be 200 to 2400 milligrams per day, orally divided into 2 to 3 doses. there's potential bronchoconstrictive effects. So patient with asthma, pre-existing myocardial disease, decompensating cardiac function, or heart block and bradycardia should be avoiding labetalol. Nifedipine, 30 to 130 milligrams, oral extended release. Commonly starts at 30 to 60 once a daily. Immediate release formulation is used for inpatient acute elevated blood pressures and should be avoided in patients with tachycardia. Methodopa, 500 to 3,000 milligrams daily in 2 to 4 divided doses. Commonly starts at 250 milligrams twice to 3 times a day. This might not be as effective as other medication. And it's limited by side effects such as sedation, depression, and dizziness. Hydrochlorothiazide, 12.5 to 50 milligrams daily. This is second to third line agent. And then we have acute urgent blood pressure control in pregnancy. Labetalol again. This time IV, we can do 20, 40, 80, 80, 80 for a max of 300 milligrams. Before it was 2400 milligrams. Now it's 300 milligrams. Tachycardia is less common and fewer adverse effects than other agents. Avoiding same as before, onset of action 1 to 2 minutes. So this could be given every 10 minutes. Hydralazine, 5 milligrams IM or IV, then 5 to 10 milligrams IV every 20 to 40 minutes to a maximum dose of 20 milligram. Higher or frequent dose associated with maternal hypotension, headaches, abnormal fetal heart tracing, may be more onset of action is 10 to 20 minutes. Nifedipine, 10 to 20 milligrams orally, repeat in 20 minutes if needed, then 10 to 20 milligrams every 2 to 6 hours. We can see reflex tachycardia and headaches, onset of action 5 to 10 minutes. Also of note, epidural can lower blood pressure by 15%. Lowering diastolic blood pressure less than 80 can cause fatal heart rate abnormalities. So labetalol is a alpha and beta blocker. Like I said, the onset of action is 5 minutes. So you check 5 to 10 every 5 to 10 minutes. Contraindications we talked about earlier. Hydralazine about 20 minutes onset of action. 50% of patients can have reflex tachycardia, hypotension, headache, palpitation, flushing, anxiety, tremor, vomiting, epigastric pain. Nifedipine immediate release should be used in urgent situation. Second line agents, nicardipine, esmolol by infusion pump, IV enalapril. Aspirin should not be given if the patient has risk for GI bleeding, such as a bleeding disorder or peptic ulcer disease. Antenatal surveillance, third trimester ultrasound should be done for fetal growth restriction risks. Delivery, if the patient is not on meds, 38 to 39.6. If the patient is well controlled on meds, you can deliver 37 to 39.6. Delivery before 39 weeks is associated with lower risk for preeclampsia and severe preeclampsia. If you have superimposed preeclampsia with severe features, you should probably deliver at 34 weeks if you're already past it. If uncontrolled, if the patient has uncontrolled severe hypertension, eclampsia, pulmonary edema, DIC, renal insufficiency, placental abruption, these patients should be delivered at any age. Otherwise, if they're not 34 weeks, then they can consider inpatient monitoring. Postpartum, blood pressure usually rise postpartum. We should try to keep the blood pressure less than 150 over 100. And we avoid methodopa due to risk of depression.